Hi, my name is Dr. Boucher. I'm an interventional radiologist at Mount Sinai Hospital in New York, and I'm one of the co-investigators of the Legacy study, which I'll be presenting the results of today. So the Legacy study looked at Y-90 glass microspheres in the treatment of both early and advanced stage hepatocellular carcinoma. It was supported by Boston Scientific. This is their disclaimer, and these are my disclosures. So to talk about the treatment of HCC, of course, we have to start at the BCLC staging classification. And I think the main point of takeaway is that the recommendations based on this staging classification at this point don't include Y-90, but in practice, we're using it across that spectrum. So in the US, TheraSphere is indicated for the use in radiation treatment, either as a neoadjuvant to surgery or transplantation in patients with unresectable HCC. It's also a device that's indicated for the treatment of patients with HCC who have partial or branch portal vein thrombosis or occlusion. Again, so this treatment modality can span the BCLC criteria for all patients who have HCC, depending on their specific tumor characteristics. But in particular, with the legacy population, we were looking at patients who had Child-Pugh A liver disease, solitary lesions that were less than or equal to 8 centimeters, and either ECOG 0 or 1 stage functional status. So both, again, advanced and early stage HCC. The purpose of the Legacy study was to examine the outcomes of TheraSphere when used to treat, again, early or advanced stage HCC. Why conduct this study? Well, it's a multi-center study. It was designed really to demonstrate the reproducibility of treatment outcomes across multiple centers, given the fact that the published data to date was focused on single center studies. It's also the first study to report the perfused volume absorbed dose necessary to achieve optimal and durable tumor response. And I'll go into that a little bit more detail in the results section. And just to note that Legacy is a very robust and comprehensive study. It really looked at patients, from start to finish with their TheraSphere treatment. Patients had no treatment prior to the TheraSphere treatment in this study, and then they were followed out and adverse events were evaluated up to 12 months after treatment. The treatment intent with Y-90 in our Legacy population was either as a neoadjuvant to surgery, so a bridging therapy either to resection or transplant, and for downstaging as well in patients who were outside of Milan criteria or who for whom resection was not an option, or as a destination therapy, so as a standalone treatment for patients who were not surgical candidates. Patients in this study had, again, a single lesion less than 8 centimeters. They were treated either with radiation segmentectomy or with a combination of segmentectomy and lobectomy or mixed radiation lobectomy. The sites and investigators are listed here. So there were 3 centers, including Northwestern, University of Washington, and our Mount Sinai Health System in New York. The principal investigator was Dr. Salem, and again, his co-investigators included myself, along with Dr. Riaz, Dr. Kim, Dr. Johnson, and Dr. Padia. The design of Legacy: this was a retrospective single-arm multi-center study conducted at 3 sites in the US. These were consecutive patients treated with Y-90 glass microsphere between 2014 and 2017 with a median follow-up of 30 months. Key eligibility criteria, again, HCC less than or equal to 8 centimeters. They were treated selectively with lobar treatment or with mixed administration. And they were treated for the purposes of neoadjuvant therapy to surgery or a standalone therapy. Patients all had good liver function, and they had either an ECOG status of 0 or 1, translating into a BCLC category of A or C. No prior intervention on these patients with HCC, and no patients had portal vein thrombosis or extrahepatic disease. The primary objective was twofold. It was to assess confirmed local tumor control or objective response rate, along with the duration of the response following treatment with Y-90, again, in unresectable solitary HCC lesions. And importantly, defining these endpoints, looking at the objective response, this is defined as either a complete response or a partial response, utilizing localized mRECIST. And just to clarify, that's reviewing afterwards the post-treatment imaging with modified RECIST in a local fashion, so essentially in the area of treatment with Y-90. These responses were all determined by a blinded independent central review, or a BICR. The same thing is true for the durability of response. That was determined by a BICR, and also looking again at localized modified RECIST, so within the tumor bed, the tumor treatment zone. The secondary endpoints are listed here. They're extensive, so disease control rate was also evaluated, the duration of disease control, the time to best response within the treatment area, the hepatic time to progression, the time to tumor progression, and then the progression-free survival. And these were looked at with multiple response criteria. Again, localized mRECIST, modified RECIST, and RECIST 1.1. Additionally, I'll comment later in the results section on the percent of patients who maintain their Child-Pugh A status. Maintaining their ECOG status was also looked at. Also maintaining or attaining the Milan transplant criteria. The percentage of patients that had a reduction in alpha-fetoprotein, and so on and so forth. So again, very robust study design, multi-center, data from 162 patients sequentially collected. Two primary endpoints needed to be met to consider the study successful. And all of this was reviewed by an outside independent review committee. And then a number of additional endpoints in addition to those primary endpoints were looked at, involving both safety and efficacy. So to move on to the results, baseline characteristics are listed here, and some of the important points are highlighted. So of note, 18% of patients were over 75 years of age. This is important, obviously, in a real-world population. Many patients who are elderly or older than 75 may or may not be good candidates for surgery. The ECOG breakdown, 60% were ECOG 0 and 40% were ECOG status 1, which broke down to a BCLC status of A or C. And the median tumor size was 2.6 centimeters. At this point, I'll shift a little bit and we'll talk about the absorbed dose and why that's important in these patients. There have been studies that look at explanted tumor and rad path correlation to the absorbed dose to perfused volume. So in patients who receive over 190 gray to perfused volume, they tend to have a better pathologic response or pathologic necrosis than patients who receive less than 190 gray. And the extent of tumor necrosis on histopathology correlates with tumor recurrence rates. It also correlates with overall survival. And we know that in patients who receive greater than 205 gray, that correlates positively with overall survival. So that's important when we look at again, the baseline characteristics, but focus on the gray dose that patients receive. So the absorbed dose to perfused liver volume, again, in this patient population, the median was 410 gray. Now looking at the primary efficacy outcomes, importantly for tumor response, again by local modified RECIST, in the evaluable population by the BICR confirmed response rate. The overall objective response rate, 72, but the majority of those were complete response, 71%. And if we look at best overall response, 88% achieved a best overall response, and that again broke down with 84% of those having a complete response. So really patients had, by and large, a complete response, and then very few, about 4%, having a partial response. When we look at the time to progression by localized modified RECIST at 24 months, 100% of the patients were without tumor progression within the treated tumor bed. And then by modified RECIST, 84% had no tumor progression at 24 months. If we look at progression-free survival, the percentage of patients alive and progression-free at 24 months by localized modified RECIST was 94%. And then looking at a comparison of the efficacy outcomes by localized modified RECIST, and RECIST 1.1, you can see the results here. Best response, again, achieved in 88% by localized modified RECIST, and over 76% achieved a duration of greater than or equal to 6 months' time. And notably, 97% of patients attained that best response after only one treatment. And that best response typically, or the median time to achieve that, was 4 months. So we'll look at the outcomes and safety here. As I mentioned earlier, looking at the ECOG status and the percentage of patients who maintained their ECOG status or even improved it, it was quite high. Out till 24 months, 82% maintained their ECOG status. And similarly, patients also attained or maintained their Milan criteria, 85% of patients at 24 months. And that tells us that their underlying liver function was maintained, which is obviously very important when we're treating with radiation. Looking at the safety, it goes in line with that as well. No patients experiencing any radiation-induced liver disease or failure. And the majority of adverse events were really kind of the expected side effects that are known in patients who undergo Y-90. So most of them were abdominal pain, nausea, vomiting, things that are very well managed and expected. Also, notably, there was no clinically meaningful significant difference in the safety in any of the subgroups that were analyzed. So looking based on age, tumor size, the BCLC category or their disease etiology, they had a similar safety profile across those substratifications. Looking at it, the overall survival from a breakdown of patients who either had transplant resection or patients who had standalone therapy, you can see that the curves are essentially running pretty parallel. So fairly comparable outcomes based on whether patients had definitive therapy with transplant resection versus standalone therapy with Y-90. And then looking at it by disease stage, the percent of patients who are surviving out as far as 36 months, almost 87% of patients, and then broken down by disease category. You can see that there, but they all, again, run fairly parallel to each other. So we'll talk quickly about some cases just to exemplify how we're administering TheraSphere to our legacy patients. This 64-year-old man, HCC from hepatitis C, BCLC-A, Child-Pugh-A, ECOG 0. He has a tumor that's 5.4 centimeters in size, and the perfused liver to that tumor and surrounding liver was calculated at 124 milliliters. He received 1,313 gray. That's what was calculated as the absorbed dose to that perfused volume of tissue. He achieved complete response at 127 days, and then it was confirmed again by localized MRECIST at 223 days post-treatment. And he did not go on to resection or require transplant. So here we can see these images nicely exemplifying this 5.4 centimeter lesion, enhancing segment 4B. And on the right-hand side, 3.5 years later, post-treatment, he has no residual enhancement, and this is considered a complete response. A second case here, looking at a woman, 76-year-old. She has an HCC that's a little bit larger, 7 centimeters. Was not a transplant candidate because of the size and the liver remnant being too small. This patient with BCLCC category, given her ECOG of 1, also with a Child-Pugh of A, initially treated to a perfused liver volume of 195 milliliters with 135 gray, and achieving a complete response, again, by localized modified RECIST at 86 days, and then confirmed subsequently at 183 days post-treatment. And so by BICR, she had a complete response, but there was a note of a rising AFP. Despite that, on the imaging, that she had a complete response. A second treatment was given. An addition of 75 gray to the treatment zone was administered, and she had a drop in her AFP subsequently. And so here's this very large dome lesion. Again, I'm not showing the left lobe, but the liver remnant would have been too small to undergo a right lobectomy. And she underwent 2 therapies. And at 1.5 years after the initial therapy, you can see significant reduction in the size of that tumor bed without residual enhancement. So complete response by modified RECIST, and even as well by localized modified RECIST, but by both 1.5 years after initial treatment. So in summary, in these patients who are treated with Y-90 therapy, best response with 84% having a complete response, and then only 4% having a partial response. Overall, 88% with that result, and a durable response. So 76% had over a 6-month duration to that response, with a local recurrence rate of 5.5% about. And there's a good subset of patients who had Y-90 as a standalone therapy, and those patients, some of them were, again, were elderly, who may not be surgical candidates. So that's very important to note. Again, preservation in liver function. So there was no declines in Child-Pugh status, ECOG status. The majority of patients, maintained their liver function, and there was no radiation-induced liver injury in these patients. And importantly, the overall survival compared favorably in patients who received the therapy as standalone versus those who actually went on to transplant or resection, telling us that Y-90 is glass microsphere is a good therapy for patients who may not be surgical candidates. The vast majority of patients achieved their best response with a single treatment, so 97%. And again, no new safety signals were identified. By and large, patients had some abdominal pain, nausea, vomiting, so the sort of expected post-procedure side effects. And again, just to touch on this, there was a high perfused volume absorbed dose, so the median was 410 gray, and this was well tolerated, obviously, based on the data that we've reviewed. And to talk about why that's important, that 410 gray. Again, I'll just mention this study that looked at post-explant tumors in 207 patients who were treated with TheraSphere, and you can see on the right-hand graph the correlation. If you have a histopathologic complete necrosis, the correlation with recurrence rates is pretty obvious. So a very low recurrence rate if you have a complete histopathologic necrosis versus patients who, on the other end of the spectrum, if you have a partial necrosis, so less than 50% on pathology, those patients have a higher percentage of patients will have recurrence. And so looking at the legacy patients in particular who went on to explant, those patients who had transplant or resection, and looking at the histopathology in those patients, if you break it down by 190 gray, there's still a small subset of patients who have incomplete necrosis on their pathologic slides. But if you look at the 400 gray cutoff, no patients had residual incomplete necrosis. So this is essentially telling us that that's probably a new cutoff that we should be trying to achieve in our patients, and we know that we can achieve it safely given the results from Legacy. So in conclusion, Legacy was a multi-center study. It did demonstrate the safety and efficacy of Y-90, both for early and advanced stage HCC in patients with single lesions. It was used as a neoadjuvant, both to transplant and resection, or as standalone therapy. And again, this, importantly, this cutoff of 400 gray to the perfused volume as the absorbed dose is important in terms of achieving optimal outcomes. Thank you.